Hi, everybody. My name is Anthony Fischetti. I'm the veterinary radiologist and department head of diagnostic imaging at the Schwartzman Animal Medical Center in little old New York City. Teaching interns and residents is a really big part of what I do. I love doing it. I also have a veterinary consulting company called Veterinary Imaging of New York, where we help veterinarians from all over the country with their radiographic interpretation. I'm the webmaster for the American College of Veterinary Radiology. It's acvr.org. Check us out whenever you get a chance. And I'm excited to be part of Vet Candy's Navily Prep on radiology. If you have any questions, make sure you put them in the chat so that we can answer them for you. And what do you say? Let's get started. Okay, so in the next set, we're going to do some flashcards on radiology of the abdomen, questions that you could potentially get on your board exam, Navily exam, sorry. This is what a normal cat looks like. Isn't a cat just absolutely wonderful? Human radiologists are jealous of how beautiful the anatomy is on the abdomen of a cat. You've got a kidney here. The left kidney is a little bit more caudally positioned. The right kidney is here. They overlap in this region here to give a summation effect. These are all loops of small intestine. The gas and the irregularly textured soft tissue represents feces in the colon. This is the descending colon, transverse colon, ascending colon. Mild amount of stomach gas here in the pyloric antrum. The fundus is up here. This is the liver. Liver vertebral column, pelvis, hips. On the VD view, you can see the left kidney very nicely because the colon is out of the way, but the right kidney is a bit hidden. It's hiding here. This is the head of the spleen on a VD radiograph in a cat, and this is the stomach. Oh, beautiful. Aren't they just absolute marvels? Yes, I am into cats, more so than dogs. These are what dogs look like. Dogs are wonderful too. This is great serosal detail for a dog, but you notice, that combination of fat and soft tissue and in the cat, where you can see all of those organs so beautifully. It's a little harder in dogs. It doesn't help also when they have a bunch of food in their stomach. So the kidneys, this is the left kidney, the right kidney's kind of hiding under here. This is again the head of the spleen. Sometimes you'll see the tail of the spleen ventrally in a dog. In a normal cat, you usually don't see the tail of the spleen ventrally. And yeah, and this is our liver. Let's talk about foreign bodies because those are always fun, and I can imagine them putting some foreign bodies on. This is a case we just had yesterday. This is a dog who ate a sock. And this is irregularly textured soft tissue and gas. You notice how the gas has these linear areas in it? Sorry, I'll grab the pen. And you see how there's these linear gas tracks in the soft tissue? This is kind of like the grooves inside the sock. So we see this with various textile foreign bodies. And you can see here all of those linear gases within the soft tissue. It kind of looks like the descending colon, doesn't it? But it's not, because the descending colon is to the left of midline in most dogs. And he's already got a descending colon right here. This is all small intestine, and it's in a distended segment of small intestine. You see how this small intestine goes from here to here, while other small intestines are super small and empty. That's two populations of bowel, which is what we use to, excuse me, diagnose a mechanical obstruction. This guy went to surgery and had a big sock taken out of his small intestine. This is pretty classic for linear foreign body obstruction. Notice the intestines aren't that distended, but you can see the undulating serosal margins out at the periphery and these irregular gas bubbles. This plication is what we see with cats that have swallowed a linear foreign body. Cats like to swallow linear foreign bodies, and linear foreign bodies tend to be thin, like tinsel or yarn. And as a result, they cause this plication. It's like a slouchy sock where the intestines just start to bunch up onto themselves and give you this undulating outer serosal margin. That's plication. Okay. Board exam potential question or Navily question is, when you have this linear foreign body, on what surface of the intestine will there be a perforation from the linear foreign body? And surgeons know this. The the linear foreign body likes to saw on the mesenteric surface of the small intestine, and that might not be the side that you see readily. So you have to look really, really closely for these little perforations that occur. And that's why linear foreign bodies can be lethal in these guys. So you got to really get them to surgery fast before those perforations form on the mesenteric surface of the small intestine. This is pretty classic. We like to, we just had this case the other day. This texture where the gas, instead of being in the longitudinal to the small intestine, like with a sock, these tend to be perpendicular and they tend to be associated with a square, which is, often a chunk of corn cob. It's just like one of those favorite foreign bodies that people like to see. Is this dog obstructed? Well, yeah, of course he's obstructed because some segments are severely distended and other ones are totally empty. Okay, so corn cob, that's the texture that you look for a corn cob foreign body. By the way, this guy has hip dysplasia. More on that when we get to the hips in the next section. This dog swallowed a rock, and yes, he's obstructed as well. So does it matter if it's fluid distended, soft tissue distended? No, it just matters that these segments of intestine are more distended than these here. Okay, so the two separate populations tell me that this foreign material, maybe coupled with the rock that this dog ate, are causing obstruction. Okay, he needs to go to surgery. Pyometra. Okay, there are tubes in the abdomen, but these tubes are not doing what the tubes of small intestine are doing. Notice how these tubes, not only are two of them, like here and here, but also they're pushing normal intestines cranially in the body. Okay, VD view is really important for pyometra too, because you see both horns. Here's one horn, and here's the other horn. And where are all the intestines? They've all been pushed forward. That's the definition of mass effect. Okay, mass effect is the displacement of normal structures by a mass. Okay, sometimes you don't see the mass and all you see is the mass effect. In this case, we see the mass. This is a very large uterus, and it's a large uterus most commonly seen with pyometra. Other differentials that are a lot less common are pyometra, mucometra, and uterine cancer. But that mass effect is what I want you to really pay attention to, how the intestines are being pushed cranially. That can only happen from a structure that is normally present in the caudal abdomen, like the uterus. Okay. Oh, here's a big tubular structure that's also in the caudal abdomen. But look at the texture of it, okay? And look at the shape of it. This is the colon, and this cat has severe megacolon. This is a really painful disease that we'll see in cats. This is an older cat that has been straining to defecate for a long time and now has just filled up its colon with this desiccated mineralized fecal material. It's always important to look at the pelvic inlet in your cases of megacolon. This is a normal pelvic inlet, but one of the potential differentials for megacolon is structural because the cat was hit by a car and they had a collapse of their pelvic inlet. Other differentials include chronic kidney disease, so if the kidneys look small, and if there's been caudal lumbar spinal trauma or disc herniation. Not 100% sure of any of that for these cases. These kidneys are maybe on the lower limits of normal for size. This kidney, I think, is the left kidney here, and there might be a stone in there. So what I would like to do is look at the serum biochemistry and see if this animal has chronic kidney disease as his reason for developing chronic constipation and subsequent megacolon. Okay, pretty common in cats that we see in New York City. Oh, intussusception. I don't know. How often do we diagnose it on a radiograph? This is the intussuscepted segment, and it's facing the gas-filled segment. This whole tubular structure here is all intussuscepted structure. Very hard to make that diagnosis on radiographs. I can't imagine the Navali having a radiographic diagnosis of it, but I could see us getting a video of it. This is the ileocolic junction in a cat. This is the ilium, and we're following this further caudally. And you'll notice that as this ilium gets to here, oh, geez. Sorry. I don't know where my video is. What starts a video on this gun? Oh well. Here we go. Try again. That's the iliacoic junction. This is the ilium. And this ilium starts to go into another segment of small intestine right here. Oh boy. And there's a linear foreign body inside this intussusception. Right here, you've got the intussuscepted portion of the small intestine and another segment that's swallowing it up. Okay. So this guy has a linear foreign body with an intussusception. I give you a double dose here. I think when I was in vet school, they called this like a target lesion. I don't really see a target for intussusception. I think it just looks like too many wall layerings for the small intestine, and you know, you might find better images of that in your textbooks. Maybe I shouldn't have done a video. I should have just done images. That I think if we're going to get a imaging question on an intussusception, ultrasound tends to be more of a intuitive diagnosis than on radiographs. I think it's pretty hard to diagnose an intussusception on radiographs. Oh, guess what? I just gave you another diaphragmatic hernia. We talked about this when we were talking about cardiovascular. This is another example of it. See the gas-filled intestines. What are they doing to the right of the cardiac silhouette on this DB view? The poor trachea is pushed over to the side. These are all diaphragmatic hernias that people love to give on exams because it'll drive you crazy if you've never seen one. Oh boy, GDV, remember when? Oh well, I think when you guys graduate, you know, the dean is gonna, you know, you're gonna hear the pomp and circumstance, and before that dean gives you the diploma, he's gonna say, or she's gonna say, what lateral do you put a dog in for a GDV? And you're gonna say right lateral view. Yep. And then he's gonna give you that diploma. Okay. Yeah, no one graduates without knowing that. This is a GDV. On the right lateral view, you can see this soft tissue shell that separates the pyloric antrum from the fundus. That's a sign of malposition. This compartmentalization is due to the pylorus, which is normally more ventral, being present more dorsally, and the fundus, which is normally more dorsal, being present more ventrally. Now, on the right lateral view, you get gas in the pyloric antrum, which allows you to see this soft tissue shell. So some people call that the Smurf sign. Kind of looks like a Smurf. I don't know how many people know what a Smurf is anymore. The other sign is like the big armed muscle guy like me sign. VD view can be kind of hard to make that call. It just looks like severe gastric distension. Okay. This dog's already had a nasogastric tube put in to help decrease the severity of that GDV. It's not really working, is it? Yeah, this dog needs to go to surgery and needs to have a gastropexy. Right lateral view, the view you put dogs in for a GDV. Okay, we're now going to go on to the musculoskeletal portion.
Do you want to close? Do we want to close it out and then start a new one?
Mm-hmm.
Okay. Do you want to close that one out?
No, because the last
What?
the last closing we did was saying that we're going to do musculoskeletal and abdomen in the next lecture.
Okay. Well,
sorry.
I'm going back on.
We can do separate intros at the end and just do pickups if you want.
Yeah. Whatever you want to do. I'm going to go back on mute.
Okay.
Okay.
Cool. Okay, and in our final section on radiology prep for the NAVLE, we're going to talk about the musculoskeletal system. Let's give you guys some radiology flashcards. This is panosteitis in a young dog with shifting leg lameness. This is the left crus, left tibia and fibula. This is the stifle. This is the right stifle. It's normal. You can see the normal amount of infrapatellar fat in the stifle joints. That's good. That's a sign that there isn't a fusion. But the problem that's occurring here is that on the right, there's increased opacity in the medullary cavity of the tibia. That's here, up through here, and then up through here. On the craniocaudal view, you see it on the right, but not on the left. all through here. See how it has a nice rounded margin on that side there too, and right here. This is panosteitis, so increased medullary opacity within the long bones of large, usually young, fast-growing, large to giant braid dogs with shifting leg lameness. Sometimes they'll have a fever, and yeah, this is radiology candy. We're in vet candy. This is radiology candy. Pretty straightforward, pretty easy to reproduce. So I think it finds itself on a lot of exams, including radiology exams, when you become boarded. Osteosarcoma, we got to talk about osteosarcoma. It's super, super common. And for the most part, we talk about near the knee or away from the elbow. So the distal femur is a common place for this irregular lytic appearance to the femur, osteosarcoma, primary bone tumor, or away from the elbow, distal radius, or in this case, the distal ulna, which is less common, but still, it still gets the point across that it's away from the elbow. One thing that I do not have here is proximal humerus, a very, very common place for osteosarcoma starting. The one time where near the knee, away from the elbow, doesn't work, but it's still a really common area is the distal tibia. And in that case, we're away from the knee, but it's still a very common place for primary bone tumors to start, okay? And we're just looking for various amounts of bony lysis, okay? You'll hear us talk about a long zone of transition between normal and abnormal bone. This looks very abnormal here, and then it just takes forever for there to be normal bone. Irregular periosteal reaction and cortical thinning, very important. You see it very nicely in this ulna, where it just blows out from the lateral cortex and the caudal cortex. Very common to also see a soft tissue component to these aggressive bone lesions, okay? So yeah, distal femur, distal radius, proximal humerus. Don't forget the distal tibia. Okay. Hip dysplasia, oh man. Well, this guy has hip dysplasia. I think his hip dysplasia is worse on the left compared to the right. And how do I know that? I'm looking at these little lines of new bone formation here. There's also another line right here. This is called the curvilinear caudolateral osteophyte, or the Morgan line. As a result of this new bone formation, the femoral neck is thickened. The head is fairly misshapen, okay? And there's less than 50% coverage of the acetabular cup over the femoral head. For sure. Yeah, this hip is even subluxated, okay? I would say that this hip is not normal, although the degree of osteoarthritic changes is certainly not as notable on that on the left. Why do I think this is abnormal? Well, if I drew a line over the acetabulum on this guy, I still think we would struggle to get 50% coverage of the acetabular cup over the femoral head. With that said, this guy is a lot in a lot better shape than this hip. Okay, the degree of subluxation and bony remodeling is supportive of hip dysplasia. Okay? Hip dysplasia, pretty common. There are different screening tests we do for hip dysplasia. This view is what's done for OFA screening. You have to wait till about 2 years to get 2 years of age to get a full certification from OFA. There are issues with the hip extended view. It makes the hips actually artificially look better. By torquing on that joint capsule, it makes the hips come in better. I think most people would agree, and studies have shown that the ideal assessment for screening of hips is Penn hip method, which I don't have an example of here, but another way you can assess for hip dysplasia in young dogs. You can do that in really young age, I think as early as 5 months for Penn hip. You got to wait 2 years for OFA. Next, hypertrophic osteodystrophy. We kind of see this a lot at AMC. It's one of those diseases of the fast-growing immature dog, and it's the double physis sign. You know how this is the normal physis right here, okay? And there's this extra lucency here and here. This lucency right there, okay? And then this whole lucency here. All right, so that's a lucency in the metaphysis. Corresponds to this lucency here, and this lucency here. In these guys, there's often soft tissue swelling. And guess what? There is soft tissue swelling right there. Okay. So it's a disease of the immature skeleton, large, fast-moving dogs. It can cause angular limb deformity. They oftentimes present with fevers, and they're feeling just systemically ill. We treat them supportively, and hopefully it goes away, and without problems to the physis long term. Okay, hypertrophic osteodystrophy. I want you guys to differentiate that from hypertrophic osteopathy. Okay, this is an adult dog disease, an adult multiple species disease. A lot of different species get this. And you start to see this irregular periosteal reaction. It often starts in the metacarpal bones and then rides up. Let's go down the leg on this guy. See how the periosteal reaction is really irregular? We call this a palisading type of periosteal reaction. All that palisading periosteal reaction extends to the metacarpal bones. It tends to spare the phalanges, although in this case it's so advanced that it also includes the phalanges. And there's often a lot of pain and soft tissue swelling. Oof, added a ton of soft tissue swelling. So palisading periosteal reaction of the long bones, when you see this, you have to take thoracic radiographs. This is more of the palisading periosteal reaction. See all this new bone formation coming off the cortex? And it's kind of like jutting out, kind of looks like the Palisades. I don't know how many people live in Westchester County, New York, but that's what the Palisades look like from my house. And you want to take thoracic radiographs on these because this is a paraneoplastic syndrome associated with lung tumors. This guy's got pulmonary nodules here and a very large pulmonary mass, which is not in this field of view. But what happens is we have a lung tumor in it, and there's different philosophies as to what happens, but we think that there might be a neurohormonal or a neurovascular response to the periosteum. And it's because of a tumor in the lung or a mass in the abdomen. It's actually been reported even with pregnancy. So different species have been affected with it, and these masses in the thorax most commonly or in the abdomen it could cause this paraneoplastic syndrome, cause this reaction elsewhere in your digits. If you get rid of the mass, it actually does a really good job of alleviating the clinical signs. The periosteal reaction improves or goes away completely. So yeah, if you treat the primary problem in the thorax or in the abdomen, you can address this stuff. So it's not metastasis to the periosteum, okay? It's a neurohormonal or a neurovascular response as a paraneoplastic syndrome, okay? That's really important to differentiate from something that we see in cats. This cat has swollen digits. It's an adult cat with swollen digits, okay? If you ever see a cat with swollen digits, you always got to be a little concerned, okay? See how irregular the bony reaction is in these digits. Sometimes they can be lytic, sometimes they can be reactive and produce bone. But these swollen digits are really bad news, okay? In Bell, this cat that presented to us, he had swollen front legs and also had a swollen digit in his hind leg, okay? So his right fourth digit was severely swollen as well, but didn't have that periosteal reaction. Uh-oh, what's going on with Bell? Take thoracic radiographs, okay? What's next in a case like Bell where you've got these swollen digits, areas of irregular new bone formation, as well as potentially lysis. This case has even got some irregular periosteal reaction marching up towards the metacarpal bone. That's kind of cool. And this is a congenital anomaly. This is a synostosis. He was born this way. That's not causing any problems for him. But what's the major problem is the soft tissue swelling. What's happened is pulmonary carcinoma, so this guy's lung mass, has metastasized to the appendicular skeleton. It happened in my own cat not too long ago, where you have a primary lung tumor and it metastasizes to the digits via the soft tissues or the periosteum, sometimes gets into the bone and causes lysis. This is not paraneoplastic syndrome like we see with hypertrophic osteopathy. This is lung digit syndrome, pretty unique to the cat, where you have a primary lung tumor and you just embolize and metastasize to your appendicular skeleton. Most commonly, it starts in the digits with just soft tissue swelling. lung digit syndrome. Okay, so lung digit syndrome, like we saw in our kitty cat named Belle, it's a digital metastasis from a pulmonary carcinoma. You'll see phalanges lysis, also even new bone formation, but often, most commonly, you see soft tissue swelling. Please differentiate that from hypertrophic osteopathy, which is not limited to dogs, and it's a paraneoplastic syndrome when you get periosteal reaction in the metacarpal bones, sometimes in the digits, and it's not lysis; it's periosteal reaction, and it's in response to oftentimes a lung tumor. But if you remove that lung tumor for hypertrophic osteopathy, the periosteal reaction goes away. If you remove this cat's lung tumor for lung digit syndrome, the lameness is not going to go away. It has already metastasized to the digits. Okay, so yeah, you do not take out the lung in a case where you've already diagnosed lung digit syndrome. We'll oftentimes put a needle in the swelling in the digits and get carcinoma just off of the aspirin. Okay, and of course, this should all be differentiated from HOD, hypertrophic osteodystrophy, which is that young dog lameness that we talked about, or we went down the road of bad cancer. Okay. Before we end it, we have to just do a quick intro to fracture classification. Okay, this is a transverse fracture. It goes from left to right, use both cortices, and it's a fractured femur at its diaphysis. This makes sense. Oblique fracture. Sometimes you can say short oblique if it's not that oblique. You could say long oblique. A spiral fracture has different forces going against it, right? It has more of a torsional force against it, and as a result, it spirals. Okay. Then we get into the comminuted fractures. Comminuted fractures are fracture lines that eventually connect to each other, like they do in here. Okay. I do want to differentiate comminuted, which I don't have in here. I want to differentiate comminuted from segmental fractures. So if I had another fracture here and another fracture here, that would be a segment fracture because the lines do not communicate. Okay. The minute the fracture lines communicate, that's when you get comminuted. Yeah. And the more smaller the fracture fragments are, the harder it is to reduce them. Okay. In the world of veterinary radiology, we often talk about fractures of young dogs as Salter-Harris fractures when it involves the physis, right? This is the epiphysis, the physis, and the metaphysis. In a Salter-Harris fracture, you get a fracture right across the physis, and it pops right off. The epiphysis displaces from the metaphysis. In a Salter-Harris type 2, you get incorporation of the physis. By definition, that's what a Salter-Harris fracture is. But then you also take a little chip off the metaphysis. This is most commonly seen in young dogs in the distal femur. Okay, Salter-Harris type 3 fracture, I'd say, is pretty rare. But what happens in these cases is you go through the physis and then up through the articular surface. Okay, the way to kind of help remember this is, I'd rather have a metaphyseal fracture for type 2 than have a fracture that actually goes to the joint. So yeah, fractures get worse when you go from type 1 to a type 5. Okay, we'll talk about type 6 in a second. Basically, a Salter-Harris 4 is a combination of 2 and 3 where you go through the epiphysis, the joint, through the physis, and through the metaphysis. Okay, we see this commonly in the distal aspect of the humerus in young dogs that are born. Finally, these are the radiologist's nemesis. Salter-Harris type 5. What happens with Salter-Harris type 5 is they get a crushing fracture of their physis, and you can't see it radiographically. Okay, you don't see it until there's premature closure of that physis and subsequent angular limb deformity. So yeah, to the radiologist, that's very frustrating. If I'm presented with trauma to the long bone in a puppy and I don't see a fracture, I will often say, hey, you know what? It probably would be prudent for us to just check back in 2 weeks and repeat radiographs just to help us evaluate limb growth for further evaluation of these crushing fractures, which can be so frustrating to diagnose. Okay, so yeah, Salter-Harris fractures of the growing physis. classify these fractures, huh? Long oblique. Holy cow, comminuted, right? All those connecting fracture fragments. This is the VD on that dog. And then look, this guy has physis that's open. So we can talk about Salter-Harris fractures. Goes from the articular surface through the epiphysis, intersects the physis distally, and then guess what? Look, a little metaphyseal chip right there. This is the metaphysis. So this is a Salter-Harris 4 fracture. Very common in the distal aspect of the humerus of young growing dogs. Super common fracture in New York City. We've got all those purse dogs where the dog jumps out of mom's purse, lands on their front legs, and the weight of the head of the radius just fractures right up through the lateral aspect of the humeral condyle. Poor puppy, but he'll be better because our surgeons are going to take care of him. Okay, that's my review of things that I think you might see on the NAVLE. Keep calling it boards. I guess you guys call it in the boards too, right? It's a national board exam. So that's it for this portion of the Vet Candies NAVLE prep on radiology. If you have any other questions, please drop it in the chat. And thanks for joining us today. Had a lot of fun. Thanks.